Next thing you know, she gonna be like, how you get on there? Where she at? Alright. So whose slide is this? This is, don't know. I just know it's way down here. I think we're farther along than what I think. Or what I thought. Yeah, NBC 2020. All right. So open your book to any page. It doesn't matter. I'm on 310, so if you just want to see where I am. So at the bottom of the page, the very, very bottom of the 2 pages, it's going to show you. Oh, hold on. Let me present. Present. Tab. No. Cancel. Still have something to have it. I need to call their parents. Because they're going to fail if they don't. Okay, so at the bottom of the pages where it says Cpt symbols are located throughout the Cpt coding book. At the very bottom, that's where they're located. And it tells you exactly what they're used for. So the bullet is located to the left of a number, and it identifies a new procedure and service added to the Cpt book. A triangle located to the left of the code number identifies a code description that has been revised. So this is actually, well, no, that's not perfect, but well, no, it is. So on 310, if you look up to 74018, that is a new code. That is a new code. I don't see one with a triangle, but I do see one with a double triangle. The double triangles means that it's deleted, but we haven't got that far yet. Oh, yes, it is. So the horizontal triangles surround the revised guidelines and notes. So if you look up where it says abdomen on the same page 310, and it says 7400 has been deleted to report use 74018, that's telling you that we no longer use 74000. Now we use 74018. These code descriptions are not printed in their entirety next to a code number. The plus sign. So if you go over to 311 and look up to code 74301, that is, it signifies or identifies an add-on code. So this identifies an add-on code for procedures that are commonly but not always performed at the same time and by the same surgeon. I haven't seen a lot of the circle with a line through it, but a circle with a line through it signifies that a code it should not be used with a modifier. So at the bottom, you should see the little slash. It says Modifier 51 exempt. A bullseye symbol indicates that a procedure that indicates or includes moderate sedation, meaning it has some type of anesthesia. Now the guidelines. So this part is actually this part is good where we are. So if you turn to page 312, what this section is talking about is the guidelines. So the guidelines are located at the beginning of each CPT section. So in this case, we are under radiology, and this time we're dealing with the heart. So before the heart, it gives you a paragraph or a couple of pages that explains what you're doing with those procedural codes and how they should be used. As it explains in the notes, that it should be reviewed each year before attempting to code from this section, because the codes change. And when are the codes updated?
October 1st every year.
Correct, October 1st every year. So if you work at a cardiologist and the codes change, but you're still using the codes from 2019, then you may not get paid. So you need to always update your code sets every year, because they are updated every year. As you see, they could be revised, they could be deleted, it could be exchanged. So you just need to make sure you're using the codes that you need to be using. Guidelines define and explain the assignment of codes, procedures, and services in a particular section, which is pretty much what I just said. Now, these two terms are important. So, unlisted procedure services are codes assigned when a procedure or service is performed by a provider which there is no CPT code. For me, I know we use the 5 nines, so 99999, and that's because there's no code for it. The FDA has not approved it. It's not a common procedure. But if we want to attempt to get paid or show designation that we have done a procedure, we have to code it. And 99999 is probably the best one. A special report is used when an unlisted procedure or code is reported. So what you have to do, let's say I use laser. We use cold laser treatment in a chiropractic clinic. And what it does is that it helps to heal the mitochondria of the cell, which is a powerhouse, gives it all the healing properties, the energy, and it makes you heal faster. Well, the FDA has still not approved cold laser therapy. We would submit that 5-digit 9 code, and on top of that, we would submit a special report saying why we used it. Now, are we going to get paid? Probably not. But for documentation purposes, you can definitely send it in. They may or may not, but most of the time they're not paid for it. A narrative documentation must accompany a claim to describe the nature and extent and need of the service or procedure. Some practices placed in box 19 of the CMS 1500 claim the unlisted code, the closest related code of the one you used. So cold laser. Well, if I can't use cold laser in box 19, I could put what's closest to it is therapeutic ultrasound, which is 97014. No, that's ECM 15, I think. But we could use that code that's closest to it to designate that in box 19. Because there is no code, we're going to use an unlisted code. But if we say, okay, well, when the insurance company gets this, I want them to think of what is as close to possible that I could use for this. And that's what some people use box 19 for. Did I lose anybody? So unlisted procedure services, notes of instructional notes are found throughout. Block intended note, unintended note, and indented parenthetical note. So let me find an example. Find a good example. Okay, so if you go to page 309, you go to page 309 in your CPT book. Look at code 73100. And so that first code, that is the block unintended note. So that's going to be your first code. The indented parenthetical note is underneath it. So that's another subset of that code. No. Okay. So you have a radiological exam of the wrist, 2 views. So that's one code. But then what happens if you have an X-ray of the wrist with 3 views. It still falls under that code, but it's a subset of 73100.
Oh.
So it's indented to say you can use the 73110. Because you remember you want to code to the most specific code possible. Now, there have been times where we've had cases that it'll say we took 4 views of the wrist. But there's not a 4 view here. So which one would you use? Correct. All right, Cpt modifiers. Cpt modifiers, do not forget what this means. It is to clarify services and procedures performed by providers that have always been reported on claims submitted for provider office services and procedures. A tip, a list of all the Cpt modifiers with a brief description is located on the front side of your coding manual, which you already know this. It must stand on its own to justify reporting a Modifier 25 with an E&M code. Now, on that note, because we haven't coded yet, so I'll give you an example. You have a patient that comes in first time. It's going to be more than likely a 99204. That's an initial, and it's about 45 minute visit. But they've come in with separate complaints. One, he comes in, his blood pressure is high, but then he has an infection of his foot. Those are 2 different conditions and 2 different types of exams. So instead of trying to bill for 2 exams, you bill for 1, but you let the insurance company know that, hey, he came in with blood pressure, I had to give him some blood pressure pills, and he came in with a real bad infection on his foot. So I had to treat both. You give them 25 modifier that lets them know, okay, well, he did have to do both. But whatever those conditions are, they have to be able to stand on their own. Not somebody coming in saying, oh, well, my allergies are bothering me, I'm stuffy, I'm itchy. You can't separate that. There is no separation because you don't know if they're itching from the allergies. You don't know if they ran across some poison ivy. You don't know. There's nothing separating it. But if it doesn't stand on its own, the insurance company will reject that visit. All right. E&M service must be above and beyond what is normally performed during a procedure. An E&M service is an exam. An E&M service, evaluation and management, that is an exam. It is some form of exam, a consultation, a doctor visit, a nursing home consult. It is an exam. Excuse me. Okay, we're going to skip this. I'm going to skip that. What? So we talked about this the last time. Locate the main term for the procedure or service documented. The main terms can be located by referring to the procedure or service documented, the organ or anatomical site, the condition documented in the record, or the substance being tested. Know that a synonym is a term with a similar meaning. An eponym are procedures and diagnoses named for individuals. So they're named after somebody. An eponym is named after somebody. So Epstein-Barr, the Epstein-Barr virus, Epstein and Barr came up and founded the virus. So they named it after themselves. Or Alzheimer's, that was named after somebody. Or influenza was named after body. So a lot of these viruses that you come across, they were named after someone. Abbreviations, they can also be coded, so you have to get very familiar with your medical abbreviations. We're going to skip that. We will go into more detail about the surgery section when we get to integumentary, because it's a little bit more detailed as far as the centimeters and the inches and the depth and the this and the that. But just know that when you're doing surgery, it's the incision, excision, introduction or removal, revision, repair, reconstruction, graft sutures, and other procedures. So it's a lot that goes into surgery. But like I said, we're going to go into more detail, probably not this semester, but more so next semester when we do the skin. Code surgeries properly. The 3 questions that you must ask are: what body system was involved, what anatomic site was involved, and what type of procedure was performed. Read the procedure outlined in the operative report of the E&M codes. Located at the beginning of the CPT, skip that one. Go to before assigning an EM code, evaluation management code. Make sure that you review the guidelines and apply any notes. For established patients, you need 2 of the 3 components that must be considered. And E&M codes report to a payer. They must support by documentation in the patient's record. So you can't just see a patient and you didn't really examine them. You need to have an exam first and then submit your documentation and so on and so forth, and you should be fine. The key components. The E&M code selection is based on 3 components: the extent of history, which is personal, family, social history. So it's abbreviated as PFSH, personal, family, and social history. That is everything from immunizations, traumas, childbirth, surgeries, sexual preference, any infections. Sexual preference is one of them. And then complexity of medical decision making, MDM. Make sure that you know that MDM will come and haunt you on that test. And if you don't understand what MDM is, it will mess you up when you're trying to code. It will make more sense when you are doing codes. All key components must be considered when assigning codes for new patients. So these 3 have to be considered when you're coding for a new patient. Once they're established, you don't have to worry about that anymore. The extent of the examination. Physical examination is assessment of the patient's organ and body systems. So you're going to have 4 categories: problem focus, expanded problem focus, detailed exam, and then comprehensive exam. Comprehensive exam is going to be the highest. Problem focus is going to be the least highest. And you'll see these in the codes. Mm-hmm. The primal focus is going to be the least. So if I came in and I said, "Oh, I have my throat is red, I can't swallow," what do I have? Correct. Well, if I come in and I have shivers and I have a sore, when I have shivers, I'm coughing. I have a whole lot of other stuff. Well, then we don't really know what's going on. But the easy stuff, that's primal focus. The other stuff that takes a little bit more time, it starts to get where you have to look at, okay, is this expanded? Is this a little bit more detailed? Or is this complex? Or comprehensive? Sorry, not complex, comprehensive. Yes, but the highest is comprehensive. The highest is comprehensive. And I will also show you that they are based on time. I keep moving this one, thinking I'm moving the other one. All right, so the complexity of medical decision making, MDM, there it is again. The complexity of establishing a diagnosis and or selecting a management option as a result by the number of diagnoses of management or management options. So what did it take to come to this conclusion and how are you treating them? The amount and or complexity of data to be reviewed. Do they have lab results, x-rays, etc.? And the risk of complications and or morbidity or mortality. Can they die? Will they die? We hope not. Neither. This picture here is terrible because their legs are shattered completely. And that's going to take several surgeries to heal. But the patient's record should include laboratory findings, imaging, so your MRIs, x-rays, or other test results that are significant to the management of the patient's care, a list of the known diagnoses as well as those that may exist or suspected. Now, do I do that? No. I diagnose it for what they are. If they have a diagnosis, fine. If I need to add something later, fine. But I don't diagnose on speculation. It's either there or it's not. Because what happens is if you start doing that, then you put it in the medical record or the chart, you forget it's there, and it'll keep adding up. Well, it'll keep sending to the insurance company, and they're like, "Well, why do you keep sending me this? They don't have that. They don't have this." So yeah, just code what you have. Also, the medical record needs to include the opinions of other physicians who have been consulted, a planned course of action for the patient's treatment, review of the patient's record obtained from other facilities. You keep a record of everything. I don't care where it came from, where it went, you keep a record of all of it. Because at the end of the day, you need to protect yourself. Who is emailing the mess out of me? Got it. Hey y'all.
Hey, Dr. Smith.
Hello.
I didn't even see y'all had came in. Okay, I'm going back. All right. So history and examination determined by straightforward, low complexity, moderate complexity, and high complexity. Just what it says is just what it is. When you guys just said what I had when I said I can't swallow, my throat is red, that was strep throat. That's straightforward. We already know what it is. Somebody comes in with a rash. It may not be, you might not be able to catch it right off the bat, but with a few questions, a few probing thoughts, where were you? What did you do? Oh, it's poison ivy. That's low complexity. The moderate and the high complexity start getting into more detail specific over time issues. Once the extent of the history, the extent of the exam, and the complexity of the medical decision making are determined, you can then select the appropriate E&M code. So the presenting problem. CPT defines nature of presenting a problem as a disease, condition, illness, injury, symptom, sign, finding, complaint, or other reasons for the encounter with or without a diagnosis being established at the time of an encounter. Basically, somebody comes in your office sick. That's all that meant. And these are the types of presenting patients that you will have. You will have minimal, self-limiting or minor, low severity, moderate severity, or high severity. And all this is doing is breaking the codes down into when you do start coding, you'll see where they all come together, which I really am hoping that we can get there today. Okay, so all of, I think the next couple of slides or the next ones that we're going through, I'll see, but these look like definitions. They won't make sense to you until you have to actually code it. Most codes are going to be based on time. When you look at the description of the code, it's going to tell you how many minutes that person was with the doctor, with the therapist, with whomever. So it's going to be based on time. This is face-to-face time. So the amount of time the doctor spends with the family or the patient, that is considered face-to-face time. So if you're anything like me, when you go to the doctor, I'm waiting and I'm timing because when I get my EOB, I want to know how much did you charge? How much time did you charge me? Because you weren't in here 40 minutes. You came in here, looked at me, told me hello, gave me my results, and went on my merry way. So no. But what people don't know is that the doctor can charge you for that time. Because if I'm in the office reviewing your chart, reviewing your medical records, that's still time that I'm consulting the patient. So a lot of times y'all like, man, he didn't even touch me, or he didn't even see me. Nah, nah, nah. They touched you all right through your medical record, and that's how you get charged. The next one is unit floor time. It's the same thing. It's just this is how much time the doctor is going to spend by your bedside. And I guarantee you they don't spend as nearly much time with you in the hospital. They come and look at you. How you doing? They go about their merry way. But they charge you for the time they looked at your chart. So E&M time. Claiming E&M on time, you must have the total length of time for the encounter. How long was that patient with the doctor? We used to have to do this with one of the doctors I worked with. We used to have to time him because he would be in there with the patient for 45 minutes. It is a re-exam, sir. You don't need to talk to them that long. 20 minutes, 25, get out. We can understand if it was a new patient and they had a whole lot of stuff going on. She's been here before. Let her go. You need to also add the length of time spent coordinating care and consulting the patient. So that's what I mean by reading the chart, reviewing the records. That's coordination of care. And any issues discussed. You can also bill for that as well. Relevant history, exam, and medical decision making. Again, there's MDM. You see it again. Don't forget it. Observation services. Now, this is breaking down everything. We've already done E&M. This is observation services. So, observation, this is in case you had a procedure or you went to, let's say you had surgery. You're on observation before you go home. This, you can bill for that. These are furnished in a hospital outpatient setting. The patient is considered an outpatient. They are reimbursed only when the doctor orders it. So this is not something that always happens. The subcategories of that are observation care, discharge services, and then initial observation care. Okay, I see what they're doing. I see what they're doing. So from here, this is strictly breaking down every E&M code that we have. We have the hospital inpatient services. So these are E&M codes provided to hospitals, inpatients, including partial hospitalization services. So they've gone to the emergency room, they got admitted. That's considered a partial hospitalization. And then these are all of the categories that you can bill for. I won't go over all of them, but these are the ones that are going to be considered under this subsection. The types of service provided by a physician whose opinion or advice regarding evaluation and or management of a specific problem requested by another physician or appropriate source. Okay, make sure that you understand the difference between the consultation and the consultant. The consultation is requested by another doctor or provider, and the consultant renders an opinion or advice based on the patient's condition. The consultant initiates any diagnostic or therapeutic services. The requesting physician documents in the patient's record that the request and the need for the consultation. The consultant's opinion, advice, and any services rendered are documented in the patient's record. So this would be one of those things that you see on the CMS 1500 when it says referring physician, that is where this would go. These are reported to the requesting physician or source. The subcategories include office or other outpatient consultations, inpatient consultations, and emergency. Then we have department services. This is something that's open 24 hours to provide services that are not scheduled, which is an emergency room. You have critical care services. This is when a doctor provides a service to someone who is critically ill or injured. The doctor should document the total time spent with delivering critical care services, excluding time for allowable services. Most of the time, critical care service is not covered. Here is another list of E&M codes that comes under another category. Oh, I skipped one. It's neonatal. A neonate, make sure that you know this. A neonate is a newborn up until 28 days, and an infant is 29 days to a year old. A neonate is a newborn up to 28 days, and an infant is 29 days to a year old. These categories include inpatient pediatric critical care, inpatient neonatal critical care, continuing intensive care services, and these are all for babies. But they will catch you off guard if you're not paying attention to the age of the child. Is it a neonate or infant? Or is it a newborn or an infant? Remember the days. 0 to 28, neonate. 29 to year is infant. Good job, we almost done. Nursing facilities services are provided in nursing facilities. We are talking about nursing homes. So skilled nursing, intermediate care, and long-term care. You have your initial nursing facility care, subsequent nursing facility care, nursing facility discharge care, and other facility services. So what does that mean? When they first come in, they're going to get a re-exam. They're going to get an exam because those doctors need to know what's going on with the patient. While they're there, they're going to have subsequent visits. So more than likely not a re-exam, but it's going to be a follow-up to a follow-up to make sure they're still trucking along like they're supposed to. They have nursing facility discharge services, so you have to do an exam to be discharged, either back home or to another facility. And then they have other nursing facility services that are not listed here, but they're in the book. Prolonged services. Prolonged services may be reported when a doctor's services involving patient contact are considered beyond the usual service in either an inpatient or outpatient setting. So you have prolonged physician service with the direct face-to-face, prolonged physician services without face-to-face, and physician standby or on-call services. Newborn care includes services provided to newborns in a variety of healthcare settings. Circumstances for amnesia, when situations or circumstances make anesthesia administration more difficult and increase the patient's risk factor. One, being irate, because in that means we have to restrain you. And if we have to restrain you, that means we could hurt you trying to sedate you. So that's one thing, or one incident. The physician status modifier. Each status modifier will put with an anesthesia code to indicate the patient's condition at the time anesthesia was administered. We will do modifiers. If we don't do modifiers tomorrow, we'll definitely do modifiers by the end of the week, because then you'll understand what that means. Here are the modifiers for that. But like I said, me going over them does nothing for you until you actually get to do it. Anesthesia is timed. It is 1 unit. 1 unit equals 15 minutes. Calculated anesthesia, the examination and evaluation of a patient by an anesthesiologist or a certified registered nurse anesthetist prior to administration of anesthesia. There is non-monitor interval time and recovery room time. Routine post-operative evaluation by the anesthesiologist or certified registered nurse anesthetist. Okay, so I think this is where I'm going to stop, except, hold on. Yeah, I'm going to stop on slide number, I just had it. We're going to stop on slide 76. This was at the very beginning of billing and coding. This is going to be on your certification exam. This is National Correct Coding Initiative, NCCI. It's to encourage the national correct coding methodology and manage the proper assignment of codes. Incorrect coding results in inappropriate repayment of Medicare Part B claims, and Centers for Medicare and Medicaid Services implemented the National Correct Coding Initiative. The rest of this is more or less a grid on everything that we went over, so there's no need to repeat that. So we are done with the introduction of CPT, and I promise that it's probably the longest PowerPoint ever that we will ever have to do again. The rest of it from here on out, we code. We code every day, all the time, from here on out. Any questions? All right. Well, I have your first assignment for you tomorrow. Kelly, you good?
Yes, thank you.
You're welcome. We'll see you tomorrow.
Have a nice day.
You too. This is that.